And that's another point of it is I like to talk to the family and keep them involved on what's going on. If things are bad, I'm very honest about it. Hey, we're not in a good spot right now, but we're doing the best that we can. And I want them to be a part of this process. So when it does come time to discontinue, they've been given all the information that they can be, and they can help um, feel reassured when we come get ready to discontinue. And ultimately, it's up to everybody on that team, right? If they feel comfortable with it, if one person doesn't, then guess what? We're going to work it for a little bit longer. I know our policy and procedures dictate that we can stop at a certain amount of time, especially if they've been in PEA for an extended period of time and titles less than 10. Then maybe you need to consider it, or you're considering a call for DC orders. Try to implement the family. If family says, hey, can you just work on for a couple more minutes? Absolutely, I'll be more than happy to. And that's what we're going to do. We want everybody there to feel comfortable when it comes time to discontinue CPR, that we've done everything possible and treated all possible reversible causes before we end that resuscitation. And that makes the family feel good. It makes everybody on the team feel good. It makes everyone feel like they've been a part of the entire process and they're all an equal stakeholder in that scenario. It tells us if we do have that adequate perfusion, even if we're doing good quality compressions, if we're getting good ventilation. Obviously, we're trying to do what? We're trying to perfuse, get the body to perfuse as best we can while this person's in cardiac arrest. So we understand the different types of advanced airways, but which airway is inserted through the nose to maintain an open patent airway? We have a couple options there, right? First and foremost, we can use a nasopharyngeal. And a lot of traumatic injuries, we may not want to do that. It just depends if there's a massive head bleed there or not. And I mean, it's going to have to be pretty significant not to use an MPA. Or we can do what? If that person is clinched, you may want to consider using nasal intubation. That again is going to be, up to your protocols and what you can and cannot do. Again, you need to consider, is there a basal skull fracture? What kind of Lefort fractures do we have? Does it really justify us going that route and using an ET tube to nasally intubate a patient? All right. What medication do we usually use when we have symptomatic bradycardia? For instance, let's say we get ROSC back, we have good vital signs, the patient appears to be stable, it's not showing an MI on the monitor, obviously it's going to be trauma related in nature. We've elected not to pace for whatever reason that may be. I personally would probably go to pacing. Maybe you're thinking this is more of a traumatic issue. Everything's adding up. There's no possibility that there's an underlying medical cause or vice versa. You may want to use atropine as your drug of choice in that case.